last Friday of the month, where we have Secrets of Neurology. As known to all of you, it's a knowledge feast for all neurologists. We have started today, it is 8 o'clock, and we intend to continue this by 9:30. We are extremely grateful to our course directors, Dr. Sudhir Shah and Dr. Lakshmi Narsimhan. This entire 10 months has been their brainchild, and we have been able to bring those academic feast for all of you. It's my honor and privilege to briefly introduce Dr. Sudhir Shah, Professor and Head of Department, NHL, MMC, and SBPI MSL, Ahmedabad. Sir is Director of Neuroscience at Sterling Hospital, Ahmedabad. Many laurels to his credit, but he's a modest person. He's professor and HOD, as known to all of us. He's author of 6 books, and because of his work to society, patients, and people at large, Government of India conferred prestigious Padam Shri in 2016. He's also recipient of prestigious Dr. B.C. Roy Award and recipient of various awards, just to mention UNO Award for Global Visionary Award. Dr. Shah's interest is into stroke, neurodegenerative disease, and epilepsy. Another equally stalwart is Dr. Lakshmi Narsimhan Ranganathan. Sir is Director and Professor at Institute of Neurology, Madras Medical College, the same place from where he did his DM, recipient of various awards and affiliations, just to mention a few: Paltussi Advisor from AN, A.B. Baker's Award for Global Best Teacher, Best Paper Award at AN, Global Elsevier Atlas Award. He has been executive committee members at World Federation of Neurology. He has been a teacher par excellence and has been conducting various neuro series, as known to all of us. And a very warm welcome to Dr. Priya Suthar. From here, I would request the program directors to take it forward, sir. Over to you, sir.
Thank you, Dr. Manoj, for those generous words of introduction. And we are excited to announce that this is the 10th consecutive monthly webinar of Secrets of Neurology, Knowledge Feast for All Neurologists. As you know, this has been one very consistent webinar series of Indian neurologists, and every month, last Friday, 8 o'clock, many people wait this time to log in, to listen, to communicate, to enrich themselves and understand the secrets of neurology. Thanks to all the attendees, every month they are there in strength of more than 300 or so. So it is because of their consistent zeal and inspiration that we have been able to do this program. Most important from my side is to thank my colleague, very proficient man, a wonderful human being, Professor Lakshmi Narsimhan, whose untiring efforts have made this program much more successful than what I envisaged really. I must also thank Mr. Chadda, Dr. Manoj Kumar, Dr. Haley, and total team of INTAS for successfully driving this crusade of knowledge across India. So far, we had wonderful 9 institutes of national repute who have contributed to this series. And today, in the 10th episode, we have Andhra Medical College, led by Professor G. Buchi Raju, who is a professor and HOD, Andhra Medical College. As you know, the texture of the program is like this. There will be a case presentation by the senior resident, and today it will be Dr. Priya Suthar, who is a second year postgraduate from Department of Neurology, Andhra Medical College, Visakhapatnam. She will present the case, then Dr. Satish Kumar will give some discussion across the case, and then again, Dr. Priya is likely to discuss some investigation. Then Dr. Satish Kumar is, as you know, is the assistant professor at the same college. And then Dr. Aruna Kumari, who is another assistant professor from Andhra Medical College, She would be also giving a lot of discussion and taking the case further. Thereafter, Dr. G. Buchiraju, our professor and head, a very learned man, as we know him, as a very humble and kind personality, he would be giving research advances and some clinical pulse on this topic, whatever case that is we discussed. I am very humbled and honored that all of you across India have given so much love and affection at our every request. Each college has agreed, and I am very happy to announce that next time for the 11th episode, we have one of the topmost another college, that is PGI Chandigarh, Dr. Professor Vivek Lal has instantly agreed to our request, and next month, that is May 27, Friday, 8 p.m., we await for their presentation. Professor G. Bashiraju, as you know, is a DM Neurology from AIMS, and he was initially assistant professor for 14 years, and then since 2009, he has been promoted as a professor. He has been DM examiner at several places. He is guide from nearly 30 students. He has several guest lectures. He is member of Board of Superspecialty Studies of NTI University of Health, a life member of so many august bodies, the president-elect of Andhra Pradesh Neuroscience Association, past president Vizag Neuro Club. He has contributed review article in reviews of neurology, and he has presented few papers in national and international journals. So we have a very, very learned team today. And with that words, I once again stand with folded hands to thank all of you. And with this, I request Professor G. Bachiraj to give a little introductory remark and start the proceeding for the today's case.
Uh, Good evening, everybody. In these tiring times, probably maybe it's just a diversion from our pandemic. We have this neurology secrets. I once again thank Professor Sudhir Shah and Professor Lakshmi Narsam for giving us the opportunity to present one of the interesting cases which we had seen a few months ago. Uh, uh, Initially, the case will be presented by one of the senior resident, Dr. Priya, and then it will be discussed by Dr. Satish, our assistant professor, and Dr. Arun Kumari will discuss the investigations and take it forward. And final remarks and some concluding remarks will be my. This is the flow of the program. So once again, thank Professor Lakshmi Narsaman and Sudhir Shah for giving us this opportunity, and also the INTAS people for whatever help or technical help for continuing this program. So I'll ask my resident, Dr. Priya, to first start the case presentation. Dr. Priya, share your screen.
Ma'am, you need to unmute.
Thank you, sir. Good evening, one and all. Myself, Dr. Priya, second year neurology resident from Andhra Medical College, Visakhapatnam. This is our prestigious institute, King George Hospital. So coming to the case scenario, this is 35 years old woman who is housewife hailing from Rajahmundry, presented to neurology department with chief complaints of difficulty in swallowing since 2 months, speech disturbances since 1.5 months, weakness of both upper limbs since 1 month. This patient was apparently asymptomatic 2 months ago when she developed a insidious onset, gradually progressive difficulty in swallowing, which was there for both solids and liquids. She was able to form the food bolus and able to push the food bolus to the back of mouth, and also there was sometimes nasal regurgitation of liquids on attempted swallowing. But there was no history of choking episodes. With this history of difficulty in swallowing, she visited to a local hospital in Rajahmundry, where, according to her, endoscopy was done, of which no detailed documentation is available, and she was prescribed some medications with no relief. This difficulty in swallowing went on progressing for 2 weeks, when she was able to take only semi-solids till she joined in our hospital. 15 days later, uh, also there was 15 days later, after onset of illness, she had history of speech disturbances in the which were insidious onset and gradually progressive in the form of speech became more and more strenuous, slurred, and there undue stress on the syllables, and she was having difficulty in pronunciation of labials. But there was no hesitation or pauses. There was no history of substitution of another word in place of intended word. There was history of nasal twang was there, but no history of hoarseness of voice. At the same time, she also noticed a difficulty in puffing cheeks, and also inability to drink with straw. And her family members also noticed that there is incomplete closure of her both eyelids while sleeping. She also had difficulty in shrugging of shoulders more on the right side, and also she had turning also she has difficulty in turning head sideways. But there was no difficulty. There was no. She was able to perceive smell and identify the smell. There was no blurring of vision. There was no loss of vision. There was no history of double vision or drooping of eyelid. There was no history of difficulty in chewing food or clenching teeth while brushing. There was no history of hearing loss or ringing sensation in the ear. And there was no history of difficulty in protruding tongue. 15 days later, she also noticed there was weakness of both her upper limbs, which was, according to her, more on the right side than left side. So it's insidious in onset, gradually progressive in the form of difficulty in handling cutlery, difficulty in buttoning and unbuttoning, and difficulty in removing bottle caps. Also, at the same time, she has difficulty in lifting objects from the high shelf, and difficulty in wearing her blouse. But she also had difficulty in raising her head from the pillow, but there was no difficulty in looking at the ceiling, and also there was no difficulty in turning in bed. There was no history of weakness in the lower limbs. There was no history suggestive of respiratory muscle weakness, and there was no history of double vision or drooping of eyelid. There was no history of muscle pains, or there was no history of stiffening of the extremities. There is no history of painful muscle contraction or visible muscle twitches. There was no history of any diurnal variation in the weakness, and no fatigability. So with this weakness, she visited several places at Rajahmundry, from where she has got some investigation and referred to Vishakhapatnam. This weakness also progressed over a period of 2 to 3 weeks, when she stopped working in the house, and she has to dependent on her family members for feeding, bathing, and wearing clothes. And this weakness was static some 2 weeks before she admitted to our hospital. There was also a history of transient pins and needle sensation in the whole right upper limb 1 to 2 days before the onset of weakness, but there was no history of numbness. No history. She was able to feel the clothes over the body. She was able to feel hot and cold water while bathing, and she don't have any unsteadiness of gait in darkness or after closing eyes. She don't have neck pain or radicular pain, or no girdle-like sensation. There's no history of loss of consciousness, memory disturbances, or behavioral disturbances, sleep disturbances. There's no history suggestive of emotional lability. There's no history of seizures, no history suggestive of raised ICT symptoms. There was no history of giddiness on standing, or increased or decreased sweating, fecal or urinary retention, or no history of early satiety. There's no history of involuntary movements or clumsiness of activities or disturbances of gait. There's no history of prior fever, respiratory or diarrheal illness, no history of recent vaccination or recent surgery, no history of abdominal pain or high colored urine, no history of any exposure to drugs or toxins, no history of rash, arthralgias, alopecias, no history of sore throat. History of weight loss was present since the onset of illness, which was not documented. Coming to the past history, she is not a known case of diabetes, hypertension, or CVA or seizure disorder, psychiatric illness. No history of head and spine trauma. There is no history of CNS infections in past. Her personal history: she was non-smoker, non-alcoholic, takes balanced diet, normal sleep, and appetite is decreased since the onset of illness. There is no history suggestive of sexual promiscuity. Her prior menstrual cycles were normal flow for 3 to 4 days, no dysmenorrhea, but she don't have her periods since the onset of illness. She is married at the age of 19 years and she has one live child of 13 years and history of one IUD at the age of 31 weeks of gestation. Family history is not significant. So coming to the summary, this is a 35 years old lady with insidious onset, gradually progressive bulbar palsy with asymmetrical weakness of upper limbs, proximal equal to distal, and weakness of neck flexion, minimal transient sensory symptoms with stepwise progression of symptoms for 6 weeks, and normal higher mental functions, cerebellar and autonomic features. So from this summary, we come to the core features of this case is bulbar palsy and asymmetric weakness of both upper limbs, probably of element origin, and neck flexion weakness. With these core features, the possible anatomical stage localization is first is muscle. The favorable points are subacute onset and sex. There is proximal and distal muscle weakness in upper limb and neck flexion weakness and no autonomic involvement. Unfavorable points are asymmetric onset, oropharyngeal muscle involvement at the onset of illness, upper limb weakness without lower limb weakness at onset. Neuromuscular junction, the favorable points are subacute onset, age, and sex, the bulbar weakness, and proximal and distal upper limb weakness and neck flexion weakness. The unfavorable points are persistent weakness without any fluctuations, transient sensory symptoms, and significant asymmetry in upper limb weakness. Coming to the peripheral now, particularly polyneuropathy, the favorable points are both motor and sensory features are present in this case, and there was no bowel and bladder involvement. But unfavorable points are progression over 6 weeks, and there is significant asymmetry in weakness in the upper limb. Into the next session, that is central nervous system and brainstem. The first is nuclear and intranuclear lesions. The favorable points are bilateral element type of facial weakness and bulbar palsy. The unfavorable features are no long tract signs and may be present, which may be present in the nuclear lesions. Other station, the supranuclear lesions. Here the favorable points are bulbar palsy with nasal regurgitation, but no choking episodes, and there are no long tract signs. So from these anatomic stations, the highly likely possibilities, they are peripheral now, that the first possibility is subacute variant of GBS. The subacute variant of GBS has progression beyond 1 week, but less than 8 weeks. It also presents with the relative symmetrical onset of weakness and relative symmetrical onset of weakness, bifacial palsy, and transient sensory symptoms and autonomic features. Second highly likely possibility is Lewy-Sumner variant of CIDP, which also presents with subacute onset of weakness in the upper limb, and it is asymmetrical also. Also in Lewy-Sumner variant, other cranial nerve features are also reported, like second, third, fifth and seventh cranial nerve features are also seen. In diphtheria, it presents with episode of upper respiratory tract infection or skin infection followed by a prodrome of fever, malaise, sore throat, and bluish purple membrane in the on tonsil. Later, it followed by blurring of vision and pupillary accommodation abnormalities, also bulbar palsy, and in 3 to 15 weeks, it progressed to sensory motor neuropathy. In porphyria, it is seen in third to fourth decade, which is more common in the female than males. It also presents with features of GI disturbances like abdominal pain, nausea, vomiting, also psychiatric features like confusion, delirium, seizures, anxiety, and followed by neurological symptoms which may be generalized proximal or asymmetrical weakness. Arms are more involved than the legs, and cranial nerve features are also reported in case of porphyria. In vasculitic neuropathy, although multiple mononeuropathies are common, the 30% of patients we can see the subacute onset sensory motor neuropathy. Next highly likely possibility is MMMCB, which presents of in 20 to 70 years of age, and again it is common in female. It presents with asymmetric upper limb weakness with distal prominence, and there will be subjective sensory symptoms. There are scattered reports of cranial nerve involvement in case of MMMCB. Although it is a if the cranial nerve involvement is there, it is excluded from the diagnosis of MMMCV. In paraneoplastic neuropathy, most common neuropathy is sensory polygangliopathy, but we can see the subacute onset sensory motor axonal neuropathy. Next possibility is the critical illness neuropathy. Although scenario is not fitting in for the critical illness neuropathy, but it can present at any age, more common in male. It presents with the sensory motor polyneuropathy with distal prominence. Next likely possibilities are from the neuromuscular junction. In that, first possibility is myasthenia gravis, which has bimodal presentation. First, it is in second to third decade, where it is more common in female, and the next peak is in the seventh to eighth decade, where it is more common in the male. Myasthenia gravis can also present with asymmetric ocular muscle involvement, oropharyngeal muscle involvement, and limb weakness, which may be distal, proximal and distal both. Next possibility is the botulism, which present with 12 to 36 hours after ingestion of contaminated food. It also presents with the blurring of vision, altered light reflexes, altered pupillary light reflexes, and bulbar symptoms, and autonomic features are very common in the form of dry mouth, urinary retention. Coming to the next possibility is muscle, the inflammatory myopathy like polymyositis. The polymyositis, it has acute or subacute onset with female dominance. It presents a symmetric proximal limb weakness. In polymyositis, dysphagia is also seen when polymyositis is a part of a overlap syndrome, when the dysphagia is attributed to the esophageal dysmotility or oropharyngeal dysmotility. Acute thyrotoxic myopathy, although we see chronic myopathy in case of hyperthyroidism, but there are case reports where acute thyrotoxic myopathy can be seen in a patients with hyperthyroidism. This presents with rapidly progressive bulbar features and quadriparesis, and it is very difficult to differentiate it from thyrotoxic crisis to from this acute thyrotoxic myopathy. Again, the critical illness myopathy, although the scenario is not like critical illness, but critical illness will also have similar features like critical illness myopathy, which is more common in male, and it will present as generalized flaccid weakness. Coming to the CNS abnormalities, the first thing is demyelination in pons and medulla. Examples like acute brainstem syndrome, area prostoma syndrome, where they present with intractable hiccups, nausea, vomiting. There are also vulva features like dysphagia, dysarthria. They will have gait disturbances, and postural imbalance is also seen. Other like intramedullary tumors like brainstem glioma, medulloblastoma, ependymoma, infections like NCC or tuberculoma, and vascular malformations. They present with multiple cranial nerve involvement with long tract signs. So with these possibilities, we went ahead with the general examination. This patient was conscious, cooperative. Her BMI was 24. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. No thyroid swelling or swelling elsewhere in the body. There was no markers of tuberculosis or vasculitis. There were no peripheral nerve thickening. No signs of nutritional deficiency. Her vitals was BP was 110 by 80 millimeters of mercury, right arm supine position, and 110 by 70 millimeters of mercury in standing position. There was no postural drop in blood pressure. Her pulse was 84 beats per minute, regular. Her tension volume force are normal. All peripheral pulses were equally palpable and felt bilaterally. There was no heart rate variability in standing and supine position. Her respiratory rate was 14 per minute, regular. Her breath holding time was 12 seconds. Single breath count was 20. Chest expansion was 4 centimeter, and temperature was normal. Other systems like respiratory system, normal bilateral vesicular breath sounds. In cardiovascular system, both heart sounds were normal, and per abdomen soft, non-tender, and there was no organomegaly. Into the nervous system examination, she was right-handed illiterate lady, conscious, coherent, attentive, oriented. Her MMSE was 27 by 30. She lost point in the reading, writing, and copying complex design. Her speech, spontaneous speech fluency was normal. Articulation was impaired for the labials. Otherwise, his rhythm, prosody, and pitch was normal. Then there was no paraphasias. Comprehension for S and no commands and pointing commands was normal. Naming and word finding normal. Repetition was normal. And I'm unable to check her reading, writing, and spelling to dictation, as she was illiterate. The higher mental functions were normal. Into the cranial nerve examination, first cranial nerve is normal bilaterally. She was able to perceive smell and identify smell. Second cranial nerve, her visual acuity, field of vision, color vision, and fundus examination was normal. Third, fourth, sixth cranial nerves were normal bilaterally, and there was no ptosis. Fifth cranial nerve, both motor and sensory parts were normal. Seventh cranial nerve, bilateral element type of facial palsy was present. Eighth cranial nerve, this hearing was normal. Rinne's test, air conduction was better than the bone conduction, and Weber's test was non-lateralized. Ninth and 10th, this uvula is deviated to right and palatal arches symmetrical on inspection. There was slight movement of the palatal arches on phonation, and the gag reflex was absent bilaterally. 11th now, the sternocleidomastoid and trapezius are weak. They're more on the right side than on the left side. 12th cranial now, on inspection, there was no fasciculations, atrophy, tongue tone was normal, and also power of the tongue was also normal. Coming to the motor system examination, attitude was normal, bulk was normal. There was hypotonia in both upper limbs across elbow and wrist joint, more on the right side than the left. Muscle power, neck flexion was weak, extension was normal. Upper limbs in the shoulders, all movements, flexion, extension, abduction, adduction, internal rotation, external rotation, 2 by 5 on the right side, minus 4 by 5 on the left side. Elbow, both flexion and extension, 2 by 5 on the right side, minus 4 by 5 on the left side. The wrist flexion and extension, 2 by 5 on the right side and minus 4 by 5 on the left side. The supination was weaker than pronation, and her grip was 40% on the right side and 80% on the left side. Spine flexion extension was normal. In the lower limbs, across all the joints and all the movements were 5 by 5 bilaterally. Her toe walking and heel walking was normal. Reflexes, superficial reflexes is bilateral, direct and consensual corneal and conjunctival reflexes were impaired. Abdominal reflexes were absent and plantars were flexor bilaterally. The deep tendon reflexes, there was global areflexia. There were no primitive reflexes, no involuntary movements, and no cerebellar signs. The sensory examination, spinothalamic sensations were normal, posterior column sensations were normal, and Romberg's was negative. Her gait was unremarkable, except there was decreased arm swing on on right side. There were no meningeal signs. There was no spine tenderness, and cranium was normal. So coming to the summary after examination, this is 35 years old woman with insidious onset, gradually progressive, bilateral element type 7th, 9th, 10th, 11th nerve palsy with asymmetrical proximal and distal flaccid weakness of both upper limbs and neck flexors with stepwise progression over 6 weeks and normal higher mental function, sensory cerebellum autonomic features. With this summary, the likely anatomic stations after examination, the peripheral nerve and polyneuropathy, we got an additional point of global areflexia, which is favorable for peripheral nerve. Then in neuromuscular junction, the same global areflexia has become unfavorable in case of neuromuscular junction. And the third possibility is the CNS brainstem nuclear and infranuclear lesions. The favorable and unfavorable points are the same as before the examination. With this, I will hand over to Satish sir for discussion of differential diagnosis.
I request Dr. Satish to, Priya, you unshare your...
Yes, sir.
Yeah. Satish,
Sir, are you able to hear me, sir?
Yeah.
Thank you, sir.
Share your screen.
Yes, sir. One second, sir. Everybody. So, sir, are you able to hear me, sir?
We could able to hear, but we couldn't see your screen. Did it open at your end?
Yes, sir.
But we are not able to see. Just saying has started screen sharing.
Okay.
Did you open your PowerPoint on the screen?
Yes, sir. I'm able to see, sir, but same thing. It was like your screen share is paused.
Okay. Well, like last time, maybe your Zoom app was.
Yeah, yesterday I already updated, sir.
Maybe.
Sir, once again, you can again share screen.
Otherwise, close your Zoom. You close it and again connect.
No, sir. Close and again share screen. Then it will be work. Yeah.
And send the presentation to Haley so that we can project it.
open.
Sport team, can you help?
Yes, sir.
Satish. Yeah.
Yes, now it's
Yes.
Yes, now
Yeah.
it's visible. Yes, yes, yes.
Yes.
Sir, you can go for posting.
you can start from your first slide. Yeah. Thank you.
Visible, sir.
Satish, unmute your screen, and if you want, you can.
Yes, sir. Now audible.
Yeah, audible. If you want, your video is not visible. Yeah, now it's okay. Now it's okay. Let's start.
Something problem with my actually net, sir. It's
Okay. No, go to the first slide.
yes, sir. First slide only. Not coming.
Sir, you can manually do it. You can move the screen on your, yes. And then in the downside, the arrow
Now, sir,
will
yes.
come.
Yeah, yeah.
Okay. Okay. Now it's coming.
Yes,
So,
sir.
hello.
Yeah.
Good evening, everybody. Good evening, sir, especially Dr. Lakshmi Narasimha sir and Sudesh sir for giving me the opportunity. And I'm my HOD, Dr. Buchiraju Garu. So the entire clinical scenario has been extensively discussed by Dr. Priya. So only thing is I'm summating the whole scenario after detailed clinical history and examination, sir. Here the main clinical points at the end of the examination and history. So she is actually a middle-aged female, and it is a subacute course of illness. So initially she had a without any premonitory symptoms, she had a bulbar palsy in nutshell, and followed by some weakness in the both upper limbs, which is significant asymmetry with grade more than 2 grade difference. So that along with a transient sensory symptoms. So and another major point is global areflexia. And there are no history of any long track signs or symptoms with normal higher ventral functions, no significant preceding illness of symptoms preceding the onset of illness, and no vascular risk factors, and no signs or symptoms of any connective tissue disorders. So this is in a nutshell, it's a transient sensory with sensory symptoms and predominantly motor, bulbar weakness, asymmetrical weakness of the upper limbs with global areflexia. So there are two issues in this. One, we can go in a topographical manner in the form of the involvement of structures at one point, or it's a generalized disease. So if you want to put that both the things simultaneously at one point, so we can keep the lesion in between pons and CV junction anomalies, and over a period of time it progressed one after other, with initial with bulbar palsy, followed by bilateral LMN facial weakness, and followed by both upper limb weakness, significant asymmetry. And number two is a generalized disease. The clue points with the generalized without is the global areflex. So that is the only thing we can put is a generalized disease. So by our consideration as so if you consider it as a peripheral neuropathy, so there's a generalized thing, whether it is a peripheral neuropathy or a neuromuscular junction or a muscle, or a localized related problem in between the pons and medulla. So the things in favor of first we have kept as a generalized problem because of a global areflexia, even though the weakness is in the only upper limbs and bulbar weakness, the reflexes are all in a young female, they're all lost. And some few additional findings like absent abdominal reflexes. So if you consider generalized, polyneuropathy is a first preference. So they have both motor as well as sensory features without any significant bladder or global areflexia. But only thing, an additional thing is progression. If we consider acute situation is progression over a period of 4 weeks and significant asymmetry. If you consider generalized one, significant, but there are exceptions in that. We'll go with that. Second station we can consider is a neuromuscular junction. So, but the favorable, the against points here is there is no, it's a persistent weakness, no fluctuations, and a transient sensory symptoms, and significant asymmetry in the upper limbs. Although it is a proximal, there is no involvement at all, but there is significant asymmetry grade 2 in both upper limbs, and global areflexia where there is no weakness, there is areflexia. So third we consider this as localized problem, topographical involvement of the structures depends upon the upper limb involvement and cranial limb involvement, that too predominantly the lower cranial limb till pons. So we can consider intrinsic intraaxial pathology where the pons or medulla can be involved. So the favorable points are, so both sides bilateral element facial weakness and both sides 9th, 10th and 11th cranial nerve involvement. But the against findings here we have seen is no long tract signs, no significant long tracts. So you can consider absent abdominal reflexes, but other than that, no other significant long tract signs and symptoms. So with this differential, with this we have discussed, we have put forward 3 stations. One is a peripheral nerve, number 2 is a neuromuscular junction, number 3 CNS. Our first preference initially we considered, because it is a localized problem, probably we have given less importance to the reflexes, but without any preceding symptoms, and as a gradually progressive one symptom after another over a period of around 2 months period. So initially bulbar weakness followed by bifacial weakness and followed by upper limb weakness. So first we consider actually the third possibility, that is focal lesions. So where one symptom followed by another symptom. So stepwise progression, we consider demyelination. The primary demyelinating, as the patient doesn't have any premonitory symptoms, primary demyelinating processes like NMO spectrum disorders. So demyelination at pons and the medulla and the CV junction, where intraaxial upper limbs are first predominantly involved with significant asymmetry. And another, any slow growing tumors over a period of time, or a vascular malformations which cause a neuro infections like neurocystis or cystitis or tuberculoma, which progress over a period of time. So this we have considered. After investigations and all, we considered also peripheral because of global areflexia. So where with normal acute onset weakness variants won't fit, because the progression of illness already occurred 1.5 months. So we considered a variant form of GBS where the progression of symptoms progress beyond 28 days of onset of illness. So for say bulbar onset or descending form of GB syndrome, and as a first possibility, and followed by different other things we also considered, but the clinical features or investigation, clinical features of the examination findings doesn't favor other differential diagnoses like diphtheria, although there is a upper limb onset symptoms are there in both porphyria and MMNCB, but bulbar onset symptoms are less common with MMNCB and porphyria, and no premonitory symptoms as in case of porphyria, or bulbar onset, significant bulbar onset weakness in case of MMNCB. So this we considered as a least possible, but first possibility is a variant form of GBS which has progressed, subacute variant progress over a period of time in the form descending variant in a spectrum of GBS. So next is myasthenia gravis is also we have considered, but the thing is there is no fluctuations at all. That is progress over a period of time. There are no fluctuations at any point of time, and bulbar onset weakness and over a period of time upper limb weakness, there is asymmetrical weakness. So neuromuscular junction we also kept a last possibility. So initially we considered as a demyelination or a focal lesions in the nearer to the pons and medulla, and second possibility is a peripheral because of view of global areflexia. So like this, gradually we have excluded all these things, and finally, so we put forward the 3 possibilities at the end of history and examination. So subacute polyneuropathies, out of which the first variant is a gradually the subacute forms of variants of pharyngo cervicobrachial variant of GB syndrome, and the second possibility is a central peripheral demyelination, where because the patient is having some signs like absent abdominal lacus and areflexia. So this is another condition also we consider, where central peripheral demyelination is another possibility, and least third possibility is subacute form of generalized myasthenia gravis. So with this differential diagnosis keeping in mind, we went for the investigations.
Thank you, Satish, for your elaborate discussion of the clinical both history and examination. Now, Satish stops. She's sharing the screen.
Okay, sir.
Priya, you can go ahead with the investigations.
Priya, you can go. Start share.
So there is like sharing option is not opened in my system here.
Now see, because Satish has already closed now. You could open.
So sharing option has, but home page has not come to.
And bottom in a green button, share screen option.
Yeah, that home page is not there now in my system.
So you are
Priya,
ma'am, you are logged in a browser or Zoom applications?
I'm in the browser.
Okay, so ma'am, actually download the Zoom application. Yeah. So
you have to go with that actually downloaded option only. When you click, you will get all these participants, question answer, chart, screen share, raise hand, like that. It will come in
so
the
ma'am,
down.
just download the Zoom application, and then after you can share. Yeah, Zoom. Because browser is a not available option in the share screen.
Actually,
In the meanwhile, there are some questions on clinical examination. Satish.
Yeah,
Somebody
sir. I'm able to share the screen, sir. Now.
Okay, share now.
yes.
Coming to the with all this differential diagnosis, we went ahead with the investigation. We done all the basic investigations like hemoglobin, which was 11.5 grams per cent. WBCs were 4,120 per microliter. Differential count was polymorphonucleosides were 65. The lymphocytes were 20. Monocytes were 3 and eosinophils were 2. ESR was 15 millimeters per hour. RBS random blood sugar was 110 milligram per cent. Her LFTs were normal. Renal function test, urea was 29 and creatinine was 0.9 milligram per cent. Sodium was 131 milliequivalent per liter and potassium was 3.5 milliequivalent per liter. HIV, HBs, AG and HCV negative. Serum VDRL was negative. TSH was normal. Her chest X-ray was normal. ECG was normal. Her ultrasound scan of the abdomen was unremarkable, and she already came to us with MRI brain, which was normal, the MRI cervical spine, which was normal, and the axial cuts of the cervical spine, they also normal. So over to Aruna Kumari madam for nerve conduction studies.
Dr. Aruna?
Good evening.
You start sharing your screen.
Is it visible, sir?
No, screen is not yet come. Your voice is visible.
Audible.
Sorry, audible.
Sir, is it visible now?
Yeah, yeah. Open your PowerPoint.
Good evening, one and all. Today's
Aruna,
interesting
you do
video.
enlarge your screen.
Yes, sir. Slides.
Yeah. Slideshow.
Yes, sir. Yes.
Yeah, continue.
Good evening, one and all. Today's interesting case is with a provisional diagnosis of variant of GBS. With blood investigations, routines are normal. Chest X-ray, ECG, ultrasound abdomen normal. MRI brain and cervical spine were done in the previous station and those were normal. In GBS cases, there are selective anterior nerve root enhancement with gadolinium contrast appear to be strongly suggestive of GBS. Though it is a non-specific feature, posterior nerve roots enhancement will not be there, but anterior nerve root enhancement is more suggestive of GBS. And if the cauda equina is involved, 83% of the patients show enhancement in the cauda equina nerve roots. Coming to the electrophysiology, in the RNS, there is no decremental or incremental response. One of the differential diagnoses is a neuromuscular junction disorder. So we conducted RNS, repetitive nerve stimulation test, and it was normal. In the blink test, there is bilateral facial weakness is there. So the facial CMAPs were not elicited on right side, and the CMAP amplitude on left side is less than 1 millivolt. Coming to the nerve conduction studies in limbs, the upper part is motor conductions and the lower part is sensory conductions. NCS was done in bilateral median ulnar posterior nerve and common peroneal nerve, sural nerves. Sensory motor sensory nerve action potentials are not recordable in all the sample nerves. Those are bilateral, median, ulnar, and sural nerves. Coming to the motor nerves, F waves were prolonged in left ulnar, bilateral, posterior tibial nerve. In rest of the nerves, the F waves were not recordable. In CMAP amplitudes were normal in bilateral, median, ulnar, common peroneal, and posterior tibial nerves. There is no evidence of conduction block. And distal latencies, a slight prolongation of distal latencies in bilateral median nerves. And in other nerves, it is normal. In ulnar, common peroneal, and posterior tibial nerves, distal latencies were normal. Coming to conduction velocities, they are normal in upper limbs, bilateral median and ulnar nerves, but decreased in lower limbs, both CPN and posterior tibial nerves. The impression is sensory motor axonal polyradicular neuropathy involving all 4 limbs. It is fulfilling the criteria, NINDS criteria of Amsan variant, that is decrease in CMAP amplitude and SNAPs to less than 80% of lower limit of normal, or inexcitable or absent evoked response in 2 or more nerves. So sensory all are absent, and those CMAP amplitudes were normal, other features are there. The NCS was done after 2 months of onset of weakness. And in Ho et al. Criteria is not completely fulfilling, but both sensory and motor features are there. That's why Amsan variant is considered. And in this case, the next investigation is important investigation, CSF analysis. The cells were 3 cells per cubic millimeter. More than 95% of cells are lymphocytes. And proteins were 148, that is elevated. And glucose is 54. Culture sensitivity is negative. Fungal strain negative. CBNAT is negative for tuberculosis. ADA is 3 units per liter. In CSF, elevated or rising protein levels on serial lumbar punctures and cell count less than 10, that is mononuclear cells, lymphocytes, strongly support the diagnosis of GBS. And most patients have an elevated CSF protein level more than 400, though it is less here compared to most of the patients. Normal CSF protein level is seen in 10% of the patients, and a rise in the CSF protein level may not be observed until 1 to 2 weeks after the onset of weakness. Here the patient presented to us after 2 months of weakness, though CSF protein, so the CSF protein level was elevated. Cell counts are typically less than 5, less than 10 is also considered as normal. Less than 50 is seen in HIV patients, that is CSF pleocytosis. The NCS and CSF studies confirmed the diagnosis of GBS. And coming to the variants and etiopathogenesis of GBS. The different variants of GBS, AIDP, Amman variant, AMSAN variant, pure sensory variant, Bickerstaff brainstem encephalitis, Miller-Fisher syndrome, facial diplegia, autonomic variant, and pharyngo-cervicobrachial variant. The patterns of weakness in different forms of Guillain-Barré syndrome variants. Here in our case, there is bulbar palsy and upper limb weakness, weakness of neck flexors. In pharyngeal cervical brachial variant, bulbar palsy, neck weakness, and upper limb weakness is seen. That is diagrammatic representation. Bulbar palsy, neck weakness, upper limb weakness, both upper limbs. Antecedent events in GB syndrome, respiratory illness, gastrointestinal illness, surgery, vaccination, others like drugs are the antecedent events seen in many cases, though preceding illness not always present. Here in our case, there is no preceding illness. The serological evidence of specific infections are Campylobacter jejuni, cytomegalovirus, human immunodeficiency virus, Epstein-Barr virus, Mycoplasma pneumoniae. The list may prolong in future. The pathophysiology of GBS, it is autoimmune polyradiculoneuropathy, inflammatory demyelination of proximal nerves seen, lymphocytes and macrophages, infiltration in cranial nerves, spinal roots, and peripheral nerves are seen. Immunopathogenesis is molecular mimicry and anti-ganglioside antibodies are the main pathological factors. Infections might induce an immune response, and this immune response depends on certain bacterial factors and host factors. The main thing is specificity of lipo-oligosaccharide. Antibodies to this lipo-oligosaccharide can cross-react with specific nerve gangliosides and can activate the complement cascade and causes damage to the nerve fiber or myelin, and nerve dysfunction leads to weakness and sensory symptoms. Here, when this is Campylobacter jejuni, when the infectious agent pathogens like Campylobacter jejuni infect the body, CMV, the T cells activates, and these T cells in turn activates the B cells through interleukin 4, interleukin 6, interferon gamma, all those things, and the B cells then produce antibodies. These antibodies in turn activate, crosses the blood nerve barrier and enters the nerve compartment. And here the macrophages, they directly cause damage to the myelin, and macrophage-induced complement activation may cause complement complex, and it causes myelin damage. And antibodies also cause myelin damage. It can occur from the roots to the neuromuscular junction. Antibodies causes damage at the neuromuscular junction also. Depends on the type of antibody. And node of Ranvier. Antibodies can cause damage at the node of Ranvier also. And subtypes and variants associated with IgG antibodies, different types of IgG antibodies. Here in our case, the clinically, we concluded this as a pharyngeal cervical brachial variant. And in this case, in this pattern, GT1A antibodies are seen in more than 50% of cases, followed by GQ1B antibodies, and in less number of cases, GD1A antibodies are also seen. Though the antibodies are not necessary for the diagnosis of GBS, because the negative predictive value is low and positive predictive value is also low, except for Miller-Fisher syndrome, where in 90% of the cases, the GQ1B antibodies are seen. The antibodies, occurrence of antibodies in the serum. This is the red line is infection. From the start of infection to the peak of the infection, and the infection gradually wanes off. When the infection is at the peak level, the antibodies will start, and these antibodies are came to one peak level within weeks, and then gradually they wane off. But at the end of 3 weeks, 12 weeks, that is 3 months, the antibodies will come to baseline. This is IgG antibodies. During this time, the clinical progression, initially, this is for classical GBS. Initially, the within 2 to 4 weeks, peak onset of weakness will occur, and then static for few weeks, and then the weakness is improving, coming to the whether to baseline or disability stage, static plateau phase will occur. We are considered clinically as PCB variant of GBS, and investigations wise, GBS was confirmed. And then the checklist of investigations for GBS. Routine blood tests, as already Priya told, we have done biochemistry, creatinine, RFT, LFT, etc. Those are all normal in our case. And other investigations, lumbar puncture, nerve conduction studies, they are supportive of GBS. And blood tests to consider, other blood tests are HIV serology, that was negative in this case. And Lyme serology, we are not doing routinely. And anti-ganglioside antibodies and antibodies to different infective pathogens. Other investigations to consider stool culture if necessary, and urine parfobilinogen if necessary. With this investigation checklist, any further investigations are needed to find out the etiology. Priya will tell further.
Okay, thank you, Dr. Aruna, for elaborating the investigations and something on the etiopathogenesis. Now I request Aruna, you please stop sharing your screen. Priya,
yes.
Continue.
Thank you.
Thank you, madam. With the provisional diagnosis of pharyngocervicobrachial variant of GBS, so we want to confirm our diagnosis.
Yeah, I think we have done collagen profile also, because somebody has asked this question.
Yes, sir. Yes, sir, I am showing, sir.
Okay.
So we to confirm the diagnosis of pharyngocervical brachial variant of GBS, we have sent ganglioside antibodies. To exclude other neuropathies like vascular neuropathy, we have sent ANA profile. And as the patient was admitted to us in the pandemic era of COVID, we also sent antibodies for SARS-CoV-2 infection. Okay, while awaiting for the reports, we started treating the patients first with the IV methylprednisolone 1 gram per day for 5 days, which was started on the 3rd day of admission. And we also started IVIG as soon as it was available in the dose of 2 gram per kg body weight divided over 5 days, which was started on the 7th day of admission. And by that time, we received the reports. Like here we can see the ANA antibodies, they were negative. Then all the ganglioside antibody profile was negative in this case. And this is the report of SARS-CoV-2 antibodies which were positive. Okay, they are highly positive. It was around 55.25. Okay. So with this, finally, we concluded the diagnosis of COVID-19 associated pharyngeal cervical brachial variant of GBS. But here points to be highlighted are this absence of prior history suggestive of SARS-CoV-2 infection. This can be because she may have asymptomatic infection before, and so we are having antibodies positive in her. Other two odd features like progression of illness over 6 weeks and gross asymmetry in weakness of both upper limbs. So there are case reports where the PCV variant was followed after vaccination, where we can see the progression of illness over 6 weeks, and there's also gross asymmetry in weakness of both upper limbs. And there was negative ganglioside antibody profile. So there are also case reports where PCB variant was diagnosed when there was whole antibody ganglioside antibody profile was negative. So this is one article where there is a clinical reasoning, a case of COVID-19 associated pharyngeal cervical brachial variant of GB syndrome, where they say that rare neurological manifestations are possible during COVID-19 infections, and GBS associated COVID-19 infections seems more severe than that related to other etiologies. And there also their case expands the clinical spectrum of this specific putative condition. So with this, with our treatment, the patient at the discharge, there was dysphagia was improved. There was mild persistent dysarthria was there. The power MRC grade 3/5 on the right upper limb and 4/5 the left upper limb. So in this figure, we can see her improvement. Then follow up after 1 month, there was no dysphagia. The mild persistent dysarthria was there. Power was MRC grade 4/5 right upper limb and 5/5 left upper limb. On telephonic conversation, after 4 months, there was no dysphagia and dysarthria was improved. So, thank you.
Priya, stop sharing your screen. Good evening, everybody. We thought of presenting this case as already highlighted by Dr. Priya. In this pandemic, we are seeing a lot of different neurological manifestations. One such case which we saw this, actually this patient came from Rajahmundry. Her brother is working with some orthopedic surgeons, so they sent us here, even though she was initially investigated extensively at Rajahmundry. Somebody highlighted that CT MRI showing some small gliosis in the basal ganglia. That's true, but it was not symptomatic, and as the clinical profile is not corroborating, and we have already thought of vasculitis, but no other evidence to say it's vasculitis. So coming to, as residents are there, I just want to give a review of COVID-19 and Guillain-Barré syndrome, and especially the PCB variant. As such, PCB variant is very unusual. In my last 30 years of experience, I have seen probably a dozen of PCB variant, but this is the first time I've seen such an unusual presentation of more than like 6 weeks progression and gross asymmetry in the upper limbs. These 2 points are very unusual. Maybe it's related to the pathogenesis here, probably could be COVID. So as you all aware, the neuropathogenesis in COVID is more because of the, as you all aware about the ACE receptor expression, and the spike protein of the COVID attaches to ACE receptors, even though it's more common in the lungs, but it is seen ubiquitous. As you see here, it's seen mostly in most of the parts of the central nervous system. But to highlight here is, even though the other neuropathogenesis is, as you are aware of, most common presentation of peripheral nerve is the anosmia and hypoxia, and olfactory nerve involvement, because it's at the cribriform plate, not much of durometer. So direct invasion with retrograde axonal transport and involving the brain. So that is a mode of infection, the brain and other parts. The other aspect is could be due to the transvascular and damage to blood-brain barrier. And the other one is the Trojan effect, where the infected lymphocytes are transported via the blood-brain barrier and affect the other parts of the nervous system, especially the central nervous system. But here, the important aspect is how come the peripheral nerve has been affected. So just coming to highlight the COVID-19 with the peripheral nerve system, there are nearly, now I think this is an old slide, nearly now 100 cases have been reported till now. And here we have to highlight that SARS-CoV-2 affecting the peripheral nervous system is not because of the direct effect on the ACE receptors, but the spike proteins also have what is called a dual receptor attachment to the attachment to the sialic acid containing glycoproteins and gangliosides on the cell surfaces on the peripheral nerves. And as already highlighted by Dr. Aruna regarding the molecular mimicry, these spike proteins also have affinity to the gangliosides, and there are two moieties which are similar to the peripheral nerve gangliosides, which is GA1 NAC residual on GM2. So the antibodies against the spike proteins also affect the peripheral nerve and the same epitopes, causing molecular mechanism and the formation of antibodies, and which will affect the peripheral nerve. So the peculiarity in most of these cases is, many cases, even though ADP is quite common in the West, but the literature from Italy and US, they show the cases more of Miller-Fisher variant, and other variants have also been commonly described in GD1B antibodies have been described. And somebody also asked about the management. The management doesn't differ much for the COVID response to GB syndromes. Like IVIG, IG, many of the centers have used IVIG as a first-line treatment even after methylprednisolone. Routinely, even though we had given methylprednisolone, the response is not very high, very much. So we were, as the patient is from the lower socioeconomic status, getting IVIG also took some time from government. So after a week or 10 days, we have started IVIG and had good response in the next few months. So as I already highlighted, a lot of cases of COVID with Miller-Fisher variant and also associated with anosmia, hypoxia, and ophthalmoplegia or polyneuritis cranialis, reflexia as it in our case in CSF, albumino, cytological dissociation, and many cases have shown anti-GD1 antibody. Already Dr. Aruna has highlighted the immune pathogenesis, but here the inciting agent is a viral agent, that is the spike protein of the COVID, which affects both the T cell immunity and the humoral immunity. As you all are aware that Axonal variants are more affected because of the antibodies or humoral immunity, and the demyelinating variants are more because of the TCL. So both can be affected with COVID. So as the COVID also has a dual receptor for the gangliosides and glycolipids on the peripheral nerve. So this is just to highlight both the humoral and cell-mediated immunity causing both AADP and the axonal variants. In West, actually 90% in the general series are mostly AADP, but here in most of the series, 50% also had axonal variants. Dr. Aruna has already highlighted this. The only thing I want to highlight here is why there is a predilection for some antibodies to some structures. For the residents, we have to highlight that GTA is expressed more in the peripheral lower cranial nerves like the vagus nerve, the glossopharyngeal nerve. That's why the PCB variant, the GTA antibodies are more common. Whereas in the Miller-Fisher variant, where the ophthalmoplegia and ataxia are seen, is GQ1 because these 3, 4, 6 nerves express more of GQ1 antibodies. Whereas in the demyelination, it's even though there are not much antibodies, but in 20-30% of cases there could be GM1. So actually these antibodies, depending on the affinity of these receptors which are present in these cranial nerves, cause the different patterns of GB syndrome involvement. So I already highlighted anti-GQ1 is quite commonly seen in Miller-Fisher, GM1, GM1B, GD1A, and GAL-NACD GD1 antibodies and other axonal forms like GM1 and GD1A mostly in Aman, and GT13 in PCB variant. The other point to highlight is even like, for example, if the GT1 cross reacts with the GQ1B, so sometimes you can have a PCB with a combination of Miller-Fisher. So Miller-Fisher with pharyngeal involvement. Similarly, the GQ1B can cross react with GT1 and can have a feature. So depending on which is more effective, you can get that pattern of weakness. So coming to some of the reviews which were there on GB syndrome with SARS-CoV-2, this is one of the earliest review in the first 6 months where they reported 42 cases which were published in JNNP. Here, as already Priya has highlighted, the disability is much more when patient had COVID with GB syndrome. And the other one highlighted CSF. Many studies have done, tried to get CSF and whether they could able to culture this virus. In all the studies, they could not culture the virus. So this also shows that this is not a direct viral invasion like you see in West Nile virus. So it's more of an immunopathogenesis. And so that's why there's many studies have shown, like some of the patients have started having this weakness even during hospital stay or sometimes even after hospital stay. This is one of the largest series from New York where they analyzed 4,000 patients of, in their series, 0.1% of only 3 had a COVID related GB syndrome in their series from New York. This is basically from Italy, where the 2 Italian hotspots from Lombardy, where they estimated that the incidence of GBS in COVID-19 positive patients was 47,000 per 1 lakh in COVID-19 hospitalized patients, which has gone up till 236 if you take the follow-up patients also. This study has from 12 referral hospitals and had quite a good number of cases in their series. And they also tried to compare with GBS positive COVID, following COVID and COVID negative. And here you see the disability is much more in patients who had COVID. And the scores are much, MRS sum score is much low in the COVID-19. And the other feature, as already highlighted, is the involvement of olfactory, like anosmia in nearly 20% of the cases and ophthalmoplegia. As I said, even though Miller-Fisher variant is quite rare there, more it is described in Japan and Asian. Here in this group of COVID, they had a quite significant involvement of the cranial nerves. And this is a very recent review published in Journal of Neurology, where they updated nearly 73 patients who are with COVID. And even in COVID also, 70% had a very good prognosis with IVIG. And the distribution of clinical variants subtype resemble those of classic GBS with high prevalence of classic sensory motor form, and acute inflammatory CIDP, and rare varieties like Miller-Fisher also are quite common. But they didn't report any PCB variant in this series. Just to highlight, we have seen a few cases of GB syndrome. This is our first patient who was admitted in last year in I think August, September, just in the first wave. This patient had quadripedesis, had a history of febrile illness. He was admitted in our ward. When we have sent her nasopharyngeal swab, it turned out to be RT-PCR positive and responded very well with methylprednisolone. This actually I seen in the clinic. This patient again had a paraplegic mild variant. He just came for follow-up. And when I done antibodies, these antibodies are quite positive. So if anybody has a GBS-like presentation these days, and you maybe, I don't know whether it's a chance occurrence or because anyhow it's a described neurological manifestations, many of these patients also have SARS-CoV-2 IgG positivity. Again, coming to our patient, as I already highlighted by Dr. Priya, this patient had come to us quite after 2.5 months, had a progression for nearly 1.5 to 2, for more than 6 weeks, which is unusual in most of the GB syndrome patients. And also the weakness in the upper limbs, the right side weakness is much more than left, which is very asymmetrical, which is very unusual in general PCB variant. And NCV, and as already she highlighted about the investigation, somebody pointed about a small gliosis in the brain that was there, but I think it could be incidental. And the NCV is suggestive of a Amsan type of GB syndrome. Another point which I already highlighted is usually if somebody, some residents is interested, there's a good review on Neurology Continuum recently in October 2020 on GB syndrome. See, most of the patients, the progression is, as criteria says, is mostly both in Brighton criteria and the recent group, GBS group. The progression is for 28 weeks, but we see quite few patients, like 5 to 10% can have subacute onset of GBS. We also have seen some patients where they progress for around 6 weeks. Because you label somebody as more than 8 weeks, we label them as GB syndrome, sorry, CIDP. So coming to the new diagnostic classification, which was given by the GBS classification group, published in Nature Reviews, as I already highlighted, basic in GBS is symmetry and progression from 12 hours to 28 days. These two are, in our case, she had upper limb gross asymmetry, and progression is more than, and it has actually has a stepwise progression. Initially, she had bulbar weakness, then after 2 to 4 weeks, she had weakness in the upper limbs. And these are the criteria which were given by this group on PCB. Just for the residents, one of the largest review of PCB was published in JNNP in 2014 by Benjamin in group from Yuki from Japan. Actually, Roper has described the PCB variant first in 1986. So there is actually one of the Japanese group has the highest, that is more than 100 cases of PCB variant, where they said mostly the antibodies are present only in 50 to 60% of the cases. Another 30% may not have antibodies like in our case. And they tried to exclude other conditions. And the other important point is initially many of these were diagnosed as botulinum toxin, especially in the West. Here we have to highlight that botulinum toxin also affects the ganglioside antibodies toxin. So that's why, as I said, there is affinity of GT1, GT3 for the lower cranial nerves. They can have a bulbar onset. So botulinum toxin also can have bulbar onset weakness. The diagnostic criteria, just to highlight, there is a relative symmetric oropharyngeal weakness and neck weakness and arm weakness and arm reflexia or hyporeflexia. And our patient also had, in spite of such significant involvement of bulbar and upper limb involvement, did not have any lower limb involvement except that the NCV showing changes and absent reflexes in the lower limbs. In the monophasic, as I already highlighted about the duration of the progression to from nadir is around 28 days as per the criteria, but our patient has 6 weeks of progression. And we try to exclude whatever we can exclude from all our investigations. And as like our patient, they should have albuminal cytological dissociation and CV showing neuropathy. And presence of anti-GT1A or GQ1B antibodies. So already I think this was discussed by Dr. Satish and Arun Kumari regarding the differential diagnosis. The common differential diagnosis for PCB variant is already highlighted in the West. Mostly they discuss on botulism, myasthenia, but we do consider myasthenia bulbar onset. But as this patient did not have any fluctuation and also such a gross weakness, both proximal and distal weakness in the upper limbs with gross asymmetry without any weakness in the lower limbs, and truncal weakness we thought is unlikely, and the decremental was also negative. So we didn't get MuSK antibodies or any other antibodies done. The other one is a brainstem stroke, but this is a progression for 6 weeks. So we tried to consider other intraaxial pathologies, like somebody suggested syrinx or but syrinx, actually the history is very short. Only syrinx with syringobulbia. Only 6 progression is acute onset, and MRI already by the time the patient came to us as MRI brain done twice and also MRI cervical spine, which did not show any intraaxial pathology. Otherwise, clinically, we can discuss about intraaxial pathologies like demyelination, like NMOSD spectrum disorders or other systemic, other secondary demyelinating disorders. Actually, why we presented this is we had one from Green Neurology, a clinical reasoning, a case of COVID-19 associated PCB was presented last year, end of last year. So this case is similar to that, but we had this patient was actually more in ICU with ventilatory support and all that. Our patient was quite well preserved till the end, like sensorium is not altered. And she also had, only to highlight that 6 weeks progression and asymmetry was a very interesting finding in this patient. So we try, and then COVID positive antibodies, we thought in this pandemic, we have to look for these unusual presentations, neurological presentations, we should be careful, and we try to treat these patients. And very recently in, this also I think from Lancet Neurology, there is a letter to editor where isolated bulbar palsy SARS-CoV-2, 4 case reports have been presented, and they said it could be variant of GVS, even though the German group which have published autopsy findings of 40 cases have shown some changes in the brainstem. So it could be a brainstem direct involvement, or it could be a peripheral nerve involvement because of the immunological changes. So these two are still possible, or a peripheral and central effect in these patients. So as this is also to discuss about the recent advances in management, I thought I'll put some few slides on recent advances in management of GB syndrome. Usually the treatment of choice is, even though we give, depending on socioeconomic status, for methylprednisolone, many of our patients because of the unavailability of water, but we have seen some good response with IV methylprednisolone, quite a good number of patients. But we don't have any randomized case control study to say, or it's just a natural history, but it has been seen by many of us from India. Maybe it's because of the axonal variants which are more common. And the other one is the discussion about the management combining plasmapheresis and also the IVIG. The Sandoglobulin trial with plasmapheresis, where they have given plasmapheresis followed by IVIG, hasn't shown much benefit in that trial. So recently, which was published in very recent, in last few months, is the Lancet Neurology, second, the SID GBS trial, second IV immunoglobulin dose in patients with GB syndrome with poor prognosis. Here, the response to second dose of IVIG was not very good. Side effects, especially the thromboembolic side effects, are much more significant, and they said there's not much, and the 4 patients died in the intervention group much more than the placebo, means only one IVIG group. But only one point I have to highlight here is they started IV, usually for the residents, IVIG half-life is around 2 weeks. In this study, they have used the IVIG second dose within, if I correct, is from 5 to 9 days. So they use very early. So that's why probably they tried like a booster dose, but because of the increased immunoglobulin in the blood, it must have caused thromboembolic events. But my personal experience, I remember definitely 2 patients where I used IVIG in quite sick patient. One patient is actually a CRPF constable, quite sick. She's a lady with 6 foot, more than 6 foot, quite hefty lady who was on ventilator for nearly more than 20 days. I used IVIG twice. Now she went back to her job, except for some minor distal weakness. She has done very well with 2 doses. Another patient from Coromandel also had very aggressive, like within 24 hours at 0/5 quadripedesis, also done very well with the second dose of IVIG. So when do we use the second dose of IVIG? As I said, maybe you have to wait till the second week when the half-life of the first dose is, or here one of the case reports which was published in Journal of Clinical Neurosciences. Here they used a biomarker of serum albumin. If the serum albumin has come down to 3, when they have started giving the second IV dose, the patient had good response. This is one of the case reports where the IVIG, they used serum albumin as a marker for giving a second dose when the patient is quite sick and did not respond very well with the first dose. And as you all know, IVIG, plasmapheresis IVIG is not good because the plasmapheresis dries out unless you want to wait for 2-3 weeks and then try plasmapheresis. So if you are planning to give a combination, you have to start with plasmapheresis followed by IVIG. Then coming to other complement monoclonal antibodies which affect target the other complement other pathways. There is one trial with eculizumab in patients with GBS. This is a JET-GBS trial from Japan. This is actually which was initially published in JMIR. This is the material methods, and the final multicentric double-blind phase 2A trial. This was published in Lancet Neurology. The eculizumab group did not. The outcome was there's not much difference, and the predefined response rate was not seen with eculizumab. But secondary outcome at 6 months, the improvement is much better. The patient's mobility who are on eculizumab at 6 months was much better than who are not on eculizumab. So probably, and they are planning to have a phase 3 trial with eculizumab. So maybe other complement and monoclonal antibodies against other are being planned. Just to end, so any other recent advances, recent therapeutic advances. So other complement inhibitor, a humanized antibody against the CT1 component of complement ANX005 is being studied in phase 1B trial along with IVIG in US. Just started and it's recruiting. And the other FRCN inhibitors which shorten the half-life of circulating pathogenic antineural antibodies like the rosenoleximab also has been tried. This also has been, one trial is going on with CIDP. The other modality which is an investigational product is hyperxylated IgG. So basically, as I already mentioned, here there is antibodies against the gangliosides on the peripheral now. So if you try to give hyperxylated IgG, an investigation modified product which has tenfold enhanced anti-inflammatory activity compared to IVIG and modulation of the complementary pathway has been in the very investigative trial. These are the few therapeutic advances which are being planned. Maybe we may get some conclusion in the next few years about some of the maps which affect the complement pathway may be also useful in quite sick patients, because all the even though GBS has a good prognosis with IVIG or plasma fluorescence, but quite there is some in sick patients there is quite high mortality, and even maybe because of the ventilator support and other systemic effects of the ventilator and all that. So we may need to have some other modality of treatment in a subgroup of patients who are quite sick and who did not respond to the primary therapy. So I once again thank Dr. Lakshmi Narasimhan and Sudhir Shah for giving us this opportunity. We have just highlighted the COVID and the atypical presentation, and that also a PCP variant with a progression of 6 weeks and asymmetrical. So I think if there are a lot of questions, we can try to answer those questions.
Dr. Lakshmi, please take over.
Yes, sir. Sir, thank you for a wonderful presentation, sir. And a very excellent presentation and review of all the literature regarding the COVID GBS, and a lot of points which we learned out of your the presentation. And as you rightly said, the SID GBS trial, the second dose of IVIG was, I felt was too early. Normally, we always wait, we always time the second dose IVIG between the second and the third week, because second week is where it peaks, and then around third week only we normally give. Here they gave it pretty early, and that is why the results were far less than impressive. So I thought that you made that point pretty. Hello?
Yeah.
I'm audible.
Yeah, you are audible. Continue.
Yeah, and now going to the regarding the questions. 1 minute, just a minute. The questions, one anonymous attendee has asked, I think she must be kept in the follow-up for other diagnoses like vasculitis, because COVID antibodies are now present in many patients in the second wave of SARS-CoV. This is one comment which was made. And somebody has suggested that auto antibodies like ANCA-C and P, were they done for her or not?
We haven't done, as I said, there are some limitations because of the socioeconomic status, and patient had done well with the treatment. We already, this is I think 4th or 5th month follow-up. Patient has done significant recovery with the treatment. So if there is anything, we will get back to you. But whatever investigation, basic investigation, we try to do. Like excluding other vasculitis, collagen profile, and she did not have any past history of any other systemic illness.
Dr. Rupali Mahajan has asked, is there any COVID vaccination history in your series?
No, GBS? This was actually, this, Priya, you want to ask? Answer?
So this patient was admitted with us in November 2020, when the vaccination was not started yet in India.
Yeah, no, but what they ask, in your series of GBS, is there any post-vaccinal GBS have you seen?
Actually, correct. See, I am district AFI committee. So initially, now after this second wave, before second wave, most of the patients who are having some symptoms were, whenever they're coming, they are referred to us. We had seen like one patient, one medical student who came with some ataxia, minor ataxic, we thought could be ataxic variant, or MRI is normal, and reflexes were absent. But the patient, she improved very well without conservative treatment. It was there only for a few days, so it didn't come. And one of our colleagues have seen one of the patients post-vaccine, one case of something like GB syndrome. So it has been described like any other, because it's COVID vaccination, the immune mechanisms are nearly same. So you should be looking for patients who are coming after vaccination, look for any evidence, but we haven't seen anything so significant GBS like presentations in last, except for these two patients.
Yes, Manabendra Bhattacharya, I should congratulate him. He has committed for a pharyngocervicobrachial variant of GBS when we were at the history level.
Yeah, yeah. Actually, case was simple from history only. Only thing is we tried to present because
Anyhow, but I thought
and progression for 6 weeks and asymmetry, which are very odd for a typical GBS.
And reflexes will they be intact in myasthenia gravis? One question from Dr. Sumit Kumar.
Priya, you want to answer that question?
Sir, reflexes will be intact in myasthenia gravis until it is a chronic myasthenia gravis or a burnt out myasthenia. Till that stage, the reflexes will be intact, sir.
Okay. Anyway, most of the other questions have been answered already during your talk, sir. So with this, I think I thank the entire team headed by Dr. Buchiraju, Dr. Aruna Kumari, Dr. Satish, Dr. Priya, and every one of you have done a wonderful job, and it was a real treat to watch and hear from all of you. And my sincere thanks to my mentor, Professor Sudhir Shah, and for encouraging me in all the academic activities. My sincere pronouns to him. My thanks to the entire INTAS team, Dr. Arun Chadda, Ms. Heli, and the entire team of people who have been with us all throughout our in our endeavor. And now I request, sir, Dr. Professor Sudhir Shah, sir, you want to add anything, sir?
Yeah, yes. I just wanted to congratulate and thank the entire team of Andhra Medical College headed by Professor Buchiraju. And of course, Priya did very well, so did their assistant professor. So a real congrats to the whole team. It is already 9:45 and I just wanted to re-announce that next time on 27th May, Friday, 8 p.m. we will have PGI Chandigarh team headed by Professor Vivek Lal. So they will have their case presentation. And we'll be finishing 12 webinars in the month of June, and hopefully we would like to continue thereafter with the support of and interest of all of you. Having said that, once again, I request you to take care of yourself, take care of your loved ones. This is a very difficult time. This second wave of COVID is really, really dangerous. It is not less than a tsunami or an earthquake. So, dear ones, please take care of yourselves and stay safe as far as possible. Stay home and take all precautions when you are at work. Thank you once again to one and all, and I hand over this to Mr. Chadda, thanking my colleague Dr. Lakshmi once again. Arun bhai.
Thank you, sir. It's really great that we are at the end of the 10th session of Secret of Neurology web series, which turned out to be very successful. And I, Arun Chadda, Senior General Manager, on behalf of INTAS Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence. It's audience like you that makes the presentation awesome. And first of all, I would like to thank our honorable course director, Dr. Lakshmi Narasimhan sir, and Dr. Sudhir Shah sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DME students. And I would like to thank our young neurologist, Dr. Priya, for presenting the excellent and unique case. Further to this, I would like to thank the entire Andhra Medical College team, Visakhapatnam team, Dr. Satish Kumar sir, as well as Dr. Aruna Kumari ma'am, for explaining and the proceeding of this unique case. And I am really thankful to Dr. Buchiraju sir, the HOD of Andhra Medical College, who has given his excellent expert comments of such a unique case with the fabulous presentation. The entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for gracious presence, and it's been clear being with all of you today. Thank you all for your patience, and I wish you all a very good night now, with a promise that next session on 28th May, we will meet with the most awaited next session of Secret of Neurology with PGI MER Chandigarh Neurology Department. Till then, stay safe and take care. Thank you. Thank you to all of you. Thank you, sir.
Thank you. Good night. Bye. Thank you, Dr.
Thank you,
Buttigieg.
sir. Thank you very much, sir.
Thank you.